So as a survivor, I've talked about the importance of owning your case, and I've talked about the importance of keeping a plan A, B, and C. But there's an important thing to realize that at times you have to be the patient. You have to let the medical field treat you, right? And other times you have to represent yourself.
The American Cancer Society estimated in 2007 that more than 51,000 of the new cancer cases are individuals diagnosed with kidney cancer. Kidney cancer occurs roughly twice as often in males as in females. An estimated 12,800 people died from this disease in 2006. However, it is estimated that between 100,000 and 200,000 kidney cancer survivors are living in the United States right now.
Kidney cancer is the 10th most common malignancy, and kidney cancer has an incidence similar to lymphoma. It's far less well known, even to oncologists. And I think the latter is probably because it's been so untreatable except by very specialized centers for 20 years.
Renal cell carcinoma, or RCC, is the most common type of kidney cancer, with subtypes including clear cell RCC, papillary RCC, and chromophobe RCC.
So kidney cancer refers to the type of cancer that arises in the kidney itself. There are actually a few different types of cancers that can arise in the kidney, but when we use the term kidney cancer in a conference such as this one, we're usually referring to renal cell carcinoma. That's a cancer that really arises from one of the basic elements of the kidney itself, and that accounts for about 85% of all cancers that arise in the vicinity of the kidney.
The most common cancer that comes from the kidney is something called clear cell cancer, or clear cell carcinoma, has a characteristic appearance, and that arises in the cortex of the kidney. It's on the outside, it's like the meaty bit. And then there are rarer forms of kidney cancer. The most common type of the rarer form is something called papillary or papillary, depending on where you grew up. And it comes from a slightly different area of the kidney, sort of closer to the middle, to where the urine drains. And it makes up about maybe 15 or 20% of kidney cancers.
It's a very shocking time, as it would be for any new cancer diagnosis. And traditionally, kidney cancer has carried very ominous connotations.
When you're newly diagnosed with cancer, you need to go to a specialist, and you need to go to a center of excellence, and at least for an opinion. If you can't get your care there, at least you have the opportunity to hear the way an expert would treat your cancer.
As I often tell patients, when it comes to the management of advanced renal cell carcinoma, with multiple available therapies now, this is much more of a marathon than a sprint, and it's much more a matter of trying to have control of the tumor on a month after month basis while making each of those months as high quality as possible, minimizing side effects while gaining control of their tumor and maintaining control of their tumor. And we found increasingly that we've been able to do that for not just months, but years and years for many patients.
I would recommend to those patients to contact the Kidney Cancer Association. They are truly a patient advocacy and patient-based organization with a wealth of information, and they collect it and serve patients internationally all over the world.
A third of patients have symptoms, which include blood in the urine, flank pain, fevers and night sweats, weight loss. But 2/3 of people are diagnosed accidentally. And it's almost like they go in for a chest x-ray and somebody sees something on the x-ray, or they go in for symptoms of gallbladder disease and the technician does an ultrasound and finds a kidney mass in addition to gallstones. So it's a pretty tricky disease in that respect.
So kidney cancer has somewhat of a unique distribution across the population subgroups, if you will. It's fair to say that men are much more likely to contract kidney cancer than women, for reasons that we still don't understand, but there's about 2 cases of kidney cancer amongst men for every case there is amongst women. And we believe that might have to do with hormonal factors, but frankly haven't really nailed down why that would be.
There's no question that we see an increase in the incidence of kidney cancer in older people, and that's in part because of the trend towards people living longer.
As the population ages, if you will, across the decades of the 60s, 70s, and 80 years of age, that's when the incidence of kidney cancer really rises dramatically. So in the general population, if you look at renal cell carcinoma, it is a disease of patients who are older. And the significance of that really, particularly in considering the new therapies that we have to treat advanced kidney cancer, is that many of those patients will have other medical conditions that they'll have compiled by that time that they've developed kidney cancer. And that really forces us to question what is the interface of the new therapies in terms of those other diseases that patients have, not just their renal cell carcinoma. And that has been a challenge. The newer therapies cause some side effects that can complicate the management of problems that an elderly population is already wrestling with. Hypertension, increase in blood sugar are two nice examples of what the newer therapies will commonly do as side effects along the way towards translating to control of their disease. And these really do raise challenges where medical oncologists and other practitioners who use these therapies to treat patients with advanced kidney cancer need to be managing these patients in conjunction with generalists and other specialists potentially who can help keep tabs on all of those problems.
There is a sense, albeit anecdotal, that it is a slower growing process in older people. I have, for example, a woman who's 80 years old who had bilateral kidney cancer, had one kidney removed, refused to have the other one removed because she did not want to be on dialysis. And I've been following her for over 10 years, and she has not progressed with that other kidney cancer.
In terms of other groups who are more likely to contract kidney cancer or have it behave more aggressively, we've also learned that African Americans are more likely to contract the disease in the first place and have it behave more aggressively if they do contract it. And again, that ratio, if you will, is that kidney cancer is about twice as likely in African Americans as it is in Caucasians.
Risk factors for developing the disease have been associated with cigarette smoking. There's an increased relationship with hypertension. Which comes first, it's not clear. Certainly kidney tumors can produce hypertension, and when the kidney's removed, the hypertension disappears.
There are familial cases of renal cell carcinoma that occur, and in those families where renal cell carcinoma affects multiple individuals across multiple generations of the family, we found the underpinnings, if you will, the genetic predisposition that leads to that. Having said that, if you look at all renal cell carcinomas and consider how many renal cell carcinomas occur in families like that versus how many renal cell carcinomas occur in one individual who's the only person in their family plus or minus one generation, you find that nearly all renal cell carcinomas are of the type that happen, as we say, sporadically, meaning one individual in a family, not multiple affected family members. So you're down into the 1% to 2% range of all renal cell carcinomas that actually run in families in a fairly consistent fashion. Now, does that mean that there's not some genetic predisposition even in those cases? There could be. It's just not as strong a link as is in those families that have multiple generations and multiple affected family members.
Catherine Fillion, I think, represents the best instance of the empowered patient.
I'm Catherine Fillion. I'm from Houston, Texas. I'm a kidney cancer 13-and-a-half-year survivor.
Catherine is a more than 13-year survivor of stage 4, that's metastatic kidney cancer. And Catherine will tell you that she has survived because she learned about the disease process. She closely evaluated the physicians who proposed to treat her and evaluated the treatments that they proposed. By educating herself about this disease, what she found over time is that there were instances where she knew more about the disease process and how best to treat it than the people who were treating her. It sounds trite, but the most important thing for anyone dealing with a difficult medical prognosis is to remember that knowledge is power.